I'm making this presentation as part on behalf of my team, which includes the person at WHO headquarters who leads the work on self-care interventions, Manjula Narasimhan, and also another colleague, Carl Masrano. As mentioned by Sophia, my name is Kabir. I am based in Nairobi, but currently presenting from my home country, which is India. Next, please. So you saw the video, and maybe there was a lot of information for you to digest. So I will start my presentation with a terminology to make sure that all of us are on the same page. It appears that the term self-care is used increasingly in a range of spaces and platforms, and it's very important for us today to make sure that we're all on the same page and that we understand self-care and self-care interventions in the same way. I will also talk about the critical relationship between self-care interventions and health systems, and then move to the heart of the self-care interventions discussion, which is the conceptual framework, which is critical. And then I'll provide you an overview of the guideline to give you a snapshot, a sense of the guideline, and maybe a flavor of what some of these recommendations look like. I'll also update colleagues on what is new in the new revision. As many people know, this is a living guideline which we update as and when evidence is available. So it's important for us all to stay updated. I will then talk briefly about classification of self-care interventions, which is very much about making sure that there is shared language that is being used and understood in the same way. And I'll end with some key resources so that colleagues webinar can go back and revisit many of the topics and issues that will be discussed today. Next, please. So it's a good opportunity for us to make sure that we understand self-care terminology and the difference between self-care and self-care interventions. Self-care, as you can see, is the ability of individuals, families, and communities to promote health, to prevent disease, but also to maintain health and cope with illness and disability with or without the support of a health worker. Now, the scope of healthcare, self-care, in this definition includes health promotion, it includes disease prevention and control, it includes self-medication, giving care to dependent people, seeking hospital care, specialist or primary care whenever needed, but also rehabilitation, including palliative care. Now, self-care interventions, on the other hand, different from self-care, is tools. These are the actual tools that support self-care. And these include evidence-based, high-quality drugs, devices, diagnostics, but also digital interventions that can be provided fully or partially outside formal health services and can be used with or without a health worker. Next, please. Now, this is really important for us to understand that self-care is not something that happens outside or in the absence of a health system. It happens very much with the health system that is around us. So it's important for us to understand how self-care interacts and engages with the health system and our everyday life. So the approach for self-care for WHO is very much a health systems approach, which means it's not about handing over responsibility to individuals, but actually to connect them with the links that exist within the health system, but also to support the health system with what more the health system might need to do to be able to enable and to sustain self-care interventions. Now, let's think of an example of an HIV self-test. And someone picks up a self-test kit for HIV from a pharmacy. Should that individual test HIV positive, what is it that they need support with in being able to come back to the health system, understanding what that HIV positive status means for them and their partner or family? They will need access to antiretrovirals. but also possibly information on how to manage their sexual and reproductive needs and rights. Now, self-care interventions broadly cover these three areas that you can see on the screen. We have self-management, self-testing, and self-awareness. Now, self-management, Petrus just talked about one example, one such intervention that would be covered under self-management, which is self-injectables for contraception. For self-testing, we could have home pregnancy test kits or HPV self-sampling, but also self-management of medical abortion. And then we have self-awareness, which covers all aspects relating to self-help, self-education, regulation, self-efficacy, and self-determination. Next, please. Now, this image we will keep coming back to, and maybe when colleagues have time to review this presentation, this is really absolutely key for us to understand this image and why it's so important. This is WHO's conceptual framework for self-care interventions. And we've put on the slide some examples from the SDG framework, so you also get a sense of how the self-care conceptual framework speaks to different aspects of the Sustainable Development Goals. But I'll start with the green at the center. The conceptual framework is just a starting point, very important for us to understand, for us to tackle this evolving, ever-changing field of self-care. The framework has core elements from the people-centered point of view, but also the health systems point of view. And it's important because it's this people-centeredness and the health systems approach that can support the introduction, the uptake, but also the scale-up of self-care interventions in diverse contexts. Now, the green that I mentioned earlier is the people-centeredness, which is very much the approach for self-care. This is at the core of the framework. Now, the self-care guideline is grounded in and it advocates for a strengthened, a comprehensive, people-centered approach to health and well-being, including for sexual reproductive health and rights. Now, if you look at the pink, I don't know how clear it is for you, but if you look at the pink circle, that has some of the key principles that are essential for us to be able to move forward on self-care. And these are principles of human rights, principles of ethics, principles around gender equality. If self-care is to be truly, truly people-centered, we must take a holistic approach to the care of each person that takes into account their individual circumstances, their diverse needs, but also their desires across their whole life course, and of course, the environment in which they live. Self-care is not an end in itself, and we must understand that people's needs, desires may change across their life course. This is very important for us to be able to understand and visualize. Also, self-care interventions need to be situated or placed in a safe and supportive enabling environment. If we are indeed to increase the participation of people in their own health, including for patient engagement. The enabling environment you can actually see in the red. I'll just go through some of them. And a lot of the aspects that Petrus has talked about, it may actually resonate with you when you hear issues about the need for a trained health workforce, the importance for health literacy and information to make sure that there are supportive laws and policies, but also aspects around commodity security. Now, it's critical that the safe and enabling environment is an area of focus for countries that are looking to introduce and sustain self-care interventions, particularly if we are to improve the health and well-being of those that are left behind or are underserved, marginalized populations. And for many countries, assessing and ensuring this enabling environment, for example, looking at the needs for training for the health workforce, is often a good starting point, as well as supportive laws and policies. We move on to the other rings that you can see here. We have accountability in blue. This is also absolutely critical to make sure, as I mentioned earlier, we're not just letting go of responsibility of the health system and need to make sure that the various moving parts or mechanics of self-care interventions include accountability for all those that are engaged in it and have a stake to ensure that there is health sector accountability, accountability for donors that support self-care interventions. What about private sector, individuals, but also government and social accountability? Next, please. Now we'll just take a closer look at this guideline, which is the 2022 revision that was mentioned earlier. This is very much a living guideline. And what that means is that this guideline will continue to be updated and expanded as new evidence becomes available, but also depending on progress with policies and programs. The best way for colleagues to stay updated is via something called the Magic app. And I will share the link. It's there on the screen, and it will be there for you when you receive this presentation. But the Magic app is where this document is live, and you will get the most updated version at any given point in time. The Magic app now includes a new web annex and 7 new recommendations that were added in 2022, which I will talk about a little later. So who is this guideline actually intended for? So the primary audience is national and international policymakers, researchers, program managers, health workers, including pharmacists, donors, civil society organizations, all of those people who are responsible for making decisions or advising on the delivery, on the promotion of self-care interventions. And then the secondary target audience is product developers. Now, as of September 2022, as I mentioned earlier, we've added some new recommendations. So now the guideline contains 46 recommendations in all across a range of topics that I will talk about a little later. But in addition to the recommendations, we also have something we call good practice statements. And there are 18 of them. And these are on programmatic issues, operational issues, issues relating to service delivery that need to be addressed by countries and stakeholders if we are all to promote safe and equitable access and support the uptake and use of self-care interventions across the life course. Now, these good practice statements, I won't go into them in detail, but they cover areas relating to gender equality, areas relating to human rights and equity, issues relating to financing, the training needs of health workers, but also issues relating to the use of digital platforms and interventions on self-care. And then we have something we call 3 key considerations. And again, as I mentioned, there are only 3 at this point, but the next iteration, there may be updates across these various issues. So the considerations that we have currently relate to self-testing for proteinuria during pregnancy, but also issues relating to pharmacy access to pre-exposure prophylaxis for HIV prevention. And we also have some recommendations on self-care during humanitarian crises. It also covers pandemics, and also a list of some essential self-care interventions during pandemics that should be considered. Next slide, please. So this is just to give us a flavor of these recommendations and the various areas that it covers. One of the topics is antenatal, intrapartum, postpartum care. As part of these, we have recommendations in the guideline that relate to self-monitoring of blood pressure and blood glucose during pregnancy, but also nutritional supplements. In the topic on family planning, including fertility, we have what Petrus just shared, self-injectable contraception, OTC availability of contraception, pregnancy self-testing, and the use of ovulation predictor kits.
safe abortion. We have self-management of medical abortion. Next, please. We have topics relating to sexually transmitted infections, reproductive tract infections, and cervical cancer. And the recommendations covered there are on self-collection of samples for STIs, HIV self-testing, self-sampling for cervical cancer screening for human papillomavirus. We have a topic on sexual health that includes use of lubricants, but also use of self-administration of gender-affirming hormones. Non-communicable diseases is a recent update as well, and this covers self-measurement to monitor blood pressure, blood coagulation, and self-monitoring of blood glucose. And communicable diseases, we have self-testing for COVID-19 and hepatitis C. Next, please. Now, in terms of what's new with this revision, there's a new web annex, which I touched upon earlier. And what that presents is it's a consolidated group of findings of 2 waves of surveys that we did, which we called Global Values and Preferences Survey. And these were conducted, I think, in 2018, and then again in 2020, 2021. And this survey was conducted among health workers and current or potential users of self-care interventions. And their responses were taken into account when actually developing these recommendations and assessing the strength of the recommendations to support updates to this guidance. A total of 194 member states participated in both waves of this survey. The new guideline for 2022 also includes communicable diseases, 2 new recommendations. One is on self-testing for COVID-19, and also we have another one on self-testing for hepatitis C virus being offered as an additional approach to HCV testing services. We have also aligned the guideline with the updated abortion guideline that was released by colleagues last year. So there's a new recommendation on pain management for self-management of medical abortion at any gestational age. We also have a new recommendation on the use of telemedicine. Again, important for us to stay abreast, updated with changes that are happening every day, particularly in the digital realm, in the digital space. And there is a new recommendation on using telemedicine as an alternative to in-person interactions with the health worker to deliver medical abortion in whole or in part. We also have a new recommendation on HPV DNA testing to screen for cervical precancer lesions and prevent cervical cancer, and also 2 other recommendations on HPV nucleic acid amplification tests, or NAT, to be able to screen for precancer lesions and prevent cervical cancer. And with communicable diseases, as mentioned, we've got COVID-19 and self-testing for Hep C. Next, please. Now, that's the guideline that I've mentioned. A lot for us to be able to understand and digest. And in the resources section, you will see that we also have an executive summary in several languages. Might be easier for colleagues to maybe start with the executive summary, because that's a snapshot pretty much. And then maybe for more detail, you could look at the guideline. Now, self-care, as we all know, has existed in some form or the other in every society. And the importance of self-care really came to the fore while responding to the COVID-19 pandemic to address some of the existing health system challenges that we all face. And it really has, in many ways, confirmed its place as an essential frontline response to healthcare. And as more and more stakeholders and countries like Myanmar make attempts to expand efforts in this field, we felt it's really important to make sure that we're on the same page, that we're speaking the same language, that we have a shared, standardized vocabulary to be able to identify gaps, address duplication, evaluate the effectiveness of what we're doing, but also to facilitate alignment across different interventions that are being implemented. So this new classification scheme is very much health systems focused as well. And what it helps us with is to give us a simplified language to help support this conversation, this dialogue between diverse public health practitioners. The focus really for this classification document is public health practitioners and audiences. And the idea is to help promote an accessible, bridging language, as I said, a connecting language for researchers, for policymakers, for donors, but also for health program managers. And this classification document was developed after a series of expert consultations and also the values and preferences survey that I mentioned earlier. And colleagues across all three levels of WHO and various UN agencies provided feedback, but also other researchers, stakeholders, policymakers. And this classification that I will share a snapshot of builds upon the format of the WHO classification of digital health interventions. And in my next slide, I'll go into a little bit more detail to give you an idea of what it covers. Next, please. Thank you so much. So you'll see over here different colors, and I'll start with the one on the pink, and then I'll show you the connection. And my apologies if I'm a bit slow. I'm looking at my telephone, which is the screen. So health system challenges and individual health needs in pink. So the classification document provides different kinds of challenges that countries may have. You may not read all of it, so I'll read through some of it. You've got health system, insufficient number of accessible health facilities. So that's issues of availability. There may be lack of information. There may be lack of access or a limited service for certain populations, which is an issue of accessibility. There could also be out-of-pocket expenses for individuals. So those are issues around cost. There could be issues of quality, poor experience for individuals. There could be issues of substandard, non-regulated health commodities. There could be issues of utilization, low demand, low uptake, low retention. There could be, I mentioned cost, high cost, out-of-pocket expenses I've already mentioned, maybe a lack of insurance policies. Another challenge could be lack of social support, insufficient community support, peer support, lack of family support, partner support. So those are some of the many challenges that health systems and countries may face, and that's in pink. And then we have in blue the self-care interventions and enabling health system actions that can be taken in response to these challenges if we are to address them appropriately. So on the one side, you've got the challenge, then the classification talks about the types of actions that can be taken. And these could be, let me see, let's try and read that as well. It'll take me a little while. Let's see. It could be issues of individual agency, self-diagnosis of health. It could be peer communication among health workers. So there are many different interventions that we could put in place to actually address many of those challenges. It could be issues of referrals. It could be self-management of health, self-diagnosis. So those are some of the many actions that can be taken. But if you remember also the conceptual framework, there was one whole ring on places of access where all of these interventions can actually be accessed. So we've already talked about pharmacies. You can access self-care interventions in health facilities, digital technologies and platforms. There could be community-based, non-facility healthcare, could be accessed at the home. Self-care interventions could be accessed at the workplace, but also through peer and partner support. For example, it could be people living with HIV as part of a peer support program that they might have in the community. Again, let's not forget life course, but also the diverse circumstances that individuals who might need self-care come from. There could be issues around emergencies during humanitarian responses, or even in some cases in school settings. And then we have, if these challenges are there, and if in blue, these are some of the interventions and enabling actions that are provided in the various places of access in orange, then we can expect a range of improved health and well-being outcomes as a result of these self-care interventions being made available. And some of them could be, outcomes could be around advancing the right to health and well-being. This could be increased agency, increased availability, increased affordability, more people-centered approaches, better digital and health literacy, improved gender equality. These are some of the improved health and well-being outcomes we can expect if we, from an advancing the right to health and well-being perspective. There could also be improved outcomes relating to the responsiveness of the health system. I think that's in the middle column, the respect for the dignity of each person, prompt responsiveness and attention to the health needs of the person, access to social support networks, having a choice, a basket of choices of self-care interventions, the fact that the health workforce is equipped to be able to promote, to be able to educate individuals, to prepare them for utilizing medications, therapeutics. Some of these issues have already been touched upon by Petrus. And finally, the third outcome, a broad area of outcome for health and well-being that can be expected is increased health accountability. This could be accountability for governments on issues relating to regulation, issues relating to commodities, issues relating to policies and programs. There could be improved donor accountability. I'm again thinking of that last string, social accountability, individual accountability, but also aspects relating to financial risk protection. So this classification document I have always found really useful to help us walk through exactly what the status is in each of our countries. What is it that we want to address? Because obviously with limited resources, countries can't do everything. And that's in the pink. Then looking at what some of the options are for countries to address that, placed or made available. And then this is what countries can expect. Again, if the people-centeredness and the key principles are adhered to. I'll stop there. I think I've spoken a lot. I'm almost 25 minutes in, but I will just say that there is a range of resources, which is the next slide. I provided links to them as well. There's a topic page on self-care interventions. We have the guideline available, the Magic app, which is an interactive platform, not the most user-friendly in terms of format, unfortunately, but at least you know when you're looking at that you've got exactly what the situation is at that point in time. There's the executive summary that I've mentioned in English, in French, in Spanish, in Russian, Chinese, Arabic. I think now also in Japanese. Then there's a policy portal where as countries adapt policies on self-care, those are uploaded onto this platform. And we are hopeful that maybe in the last quarter of this year, we will be able to have a global snapshot of the situation of self-care in terms of a policy landscape, because countries have been asked to fill out the SRM and CAH survey, which for the first time now includes a dedicated section on self-care and asks questions relating to policies. So that should give us an idea of where and how countries are moving forward. Manjula in her video talked about the increasing momentum, and we will have more evidence, of course, to support that. So that's the policy portal. There's the video that you just saw. We also have infographics on self-care and SRHR, which is for all 194 member states. So please do look up Myanmar's infographics. There's also fact sheets and also a couple of webinars, one relating to the classification document that we obviously didn't have enough time to discuss in more detail, but that will give you a deeper, better idea. And then also another webinar on some of the results from the survey that I mentioned a few times, the Global Values and Preferences survey that informed very much the recommendations and the strength of the recommendations in the guideline. So there's a lot that I've touched upon, and my apologies if I've spoken too fast for the interpreters, but I hope that colleagues have found this useful, and of course open to any questions colleagues may have. Over.
And I will really be talking about subcutaneous contraceptive injection as self-care interventions. Can everybody see my screen?
Yes, Doctor, we are clearly
Good.
see your screen.
So I will talk about scaling up of self-administrative DMPA subcutaneous, and just a little bit on the background of DMPA subcutaneous, then talking mostly about self-injection and counseling. And here I would like to say that all those slides are mostly from the training resource package, to which I will leave a link there. Then just quickly say what the global protocol is and the role of implementation science. And they've asked me to speak about one experience or two experiences, and I've decided to do the Burkina Faso experience on the self-administration. And then lastly, we will have some time, hopefully, for discussion. Then DMPA subcutaneous self-administration. Just a few facts, and I know that most of you will obviously know this, and it's not such a new injectable, but it is easier to administrate by self-injection. It's DMPA subcutaneous. Then there's a lot of pilot studies and programmatic experiences that have demonstrated that self-administration of DMPA subcutaneous is feasible and safe. So we do not, I'm sorry. So we do not need any more research to show that it works and it is safe. Kabir has just given the update on the self-care guidelines, and this DMPA subcutaneous self-administration was already in the first one that was developed in 2019. In that time, countries have expressed an interest in scaling up with self-injection with this DMPA subcutaneous. And with all this new technological advancements, the evidence of the research, the guideline development, and country interests, all these together provided us with an opportunity at the Human Reproduction team to use implementation research to help with expanding access and use of contraception. And I want to be very clear, this is as part of a bigger contraceptive mix. Then let me just close this window that came up over mine one. There we go. How do we counsel clients? And you can see there's a link on the training resource package, which is available at fptraining.org. And I want to, they really clearly explain why self-injection counseling is important, how to prepare for self-injection, how to train and counsel your clients on self-injection, including proper storage and disposal, which is very important, the proper self-injection technique, that should be with demonstration, with client self-injection, and confirming that competence. And then very important also, if you're going to give some method to somebody at home, they must calculate the re-injection dates themselves. Then we will just kind of look at quick counseling messages, and then how to conduct self-injection resupplies for visits. So I'm not going to look at, we are not going to look at all these videos, but this is really a video for women and partners. The first one on how to use DMPA subcutaneous, and it's a very short one on teaching. Second video is on also for women and partners, and that is the longer one of DMPA subcutaneous injection. And then the last one is how to give yourself an injection with subcutaneous DMPA. Once again, those videos are being made and the credits are there with PATH and JSI, but it's been taken up by the training resource packages. So why is this important to counsel self-injectors? First of all, self-injection can offer convenience and privacy, and we know that proper counseling and training helps ensure success. You have to make sure that your client are sure that this is the right choice for her. Why would people say, is this the preferred option for some women? So why, sorry, let me rephrase this to be very clear. Apologies to the interpreter. For the people who have an anxiety and fear about finding a private place to inject or securing a place to store and dispose of the unit safely, or are afraid of needles and injecting themselves, those people are not clients for self-injection at home. So the three factors that I have there shows that these people are not suitable for that. If you look at your preparing for self-injection counseling, then you should have two materials ready. First of all, on the left-hand side, there's a DMPA subcutaneous self-injection instruction job aid. You know what? When we talk now, you remember most of the things. But we always say that if you have a picture with it, then you remember better. And if you can take that picture home, it's even better. Then the second thing on the right-hand side, people should have a re-injection calendar. So what do you need to support, to prepare for the injection? The supplies for the counseling would include soap and water, the DMPA subcutaneous device or commodity, an injection model, which I will just say something about afterwards, examples of household sharp disposal containers, and then a waste basket to throw away all the other things. How can you create an injection model? You can fill a condom with either salt, sugar, or cotton. And of course, you will know that the easiest way is to wrap paper into a cone shape and then insert it on top of the condom and then fill it up with salt or sugar. Then it should be at least 3/4 full with enough room to tie off the end. At the end, after you've done it, the model should be firm but still pliable, so it is easy to gently pinch. You want to pinch it and make a little tent for that subcutaneous injection practice. So how do you conduct these trainings? Trainings can be on a one-to-one basis, like you are just talking to the client and doing the training, or you can do it in small groups. And they found that it shouldn't be more than 10 clients. But if you do train it in small groups, always have a place for a private one-on-one counseling session with each client to discuss the other all available method options, confirm a choice and the eligibility to use the DMPA subcutaneous, and then answer questions. What about storage? Storage of the DMPA subcutaneous. These people are taking these things home now, so it should be in a safe place, and it should be away from extreme heat or cold. No need to have it in a fridge. Discuss the home storage options, such as a suitcase or handbag, out of the reach of children and animals, or on a high shelf. Also, remind your client that she should not open the package until she is ready to use it, and keep it away from others to prevent injury. What about the disposal of the self-injection? So it should be discarded. The device should be discarded immediately after injection. Use a puncture-proof container with a lid so that the needle cannot come through. Store it in a safe place away from children to avoid injuries and infection. And once again, you remember there are some very curious pets as well, some cats that get around and want to see, and very curious. And then important to return those devices to the healthcare worker. So what kind of container should you use? I have a list there, and the three, I hope you can see the three in bold, because those are the three that you should use. The others that are not in bold should not be used. So what should we not use? Never use, let's start from the bottom, a narrow-necked bottle without a lid. Then second one from the bottom, which is the second non-bold one, never use the closed paper bag, never use a closed plastic bag. And then the last one is don't use the DMPA subcutaneous pouch in which it comes. So what should they have? From the top, the three bold ones, they should have a wide mouth soda bottle with a lid, some things like a petroleum jelly container with a lid, or a single-use water bottle with a lid. The main thing is, the emphasis should be that it should not, it should be closed, and it should not be punctured. It should not be punctures in it. So then it's very important to ask your clients if they have the disposable containers. Ask her what she has, and make sure that she understands that used devices may contain germs that spread disease. So what about the demonstration of the technique? You can use, as I mentioned, use the injection model to demonstrate, and there you can see in the picture that it is a full condom. Then they should follow the job A during the demonstration, and it should be step by step. Then next is the client injection practice, if needed. If the healthcare workers demonstrated self-injection, the client practice is not generally needed. That was what they found with the studies. How am I with time? All good still? I just heard, just let me know if I should. I don't want to speak too fast for the interpreter. If your clients struggle to understand the injection steps, you really want to give it a chance to practice in front of you. So here are the steps, but there are 4 critical DMPA subcutaneous steps. And the 4 are in, is it green or blue in bold again? But wash your hands if possible. Open the pouch. Then step number 1, that is critical. Mix the solution by shaking the device for 30 seconds and then check the device whether there are leakages. It must be for 30 seconds. This is not 30 seconds. This was 5 seconds, not even. Activate the device by closing the gap, and I cannot show that because I don't have it. remove the needle cap. Then third critical step, pinch the skin gently to form a tent and insert the needle. Then fourth step, that is critical, slowly press the reservoir for 5 to 7 seconds to inject. Then other steps are remove the needle from the injection site, then let go of the tent, and then discard the device. So what about competency? Encourage her to use the job aids for clients, allow her to inject herself, providing coaching as needed, confirm her injection competency, focusing on the 4 critical steps, ask if she has questions of concern. Why do we say the 4 critical steps? If you remember, some of the others are things that you actually do in any case. For instance, at the end, that are not critical steps, but that are steps they are going to do, is to take it out and discard it. Right. Then very important is to calculate the re-injection dates. They need to be able to calculate the re-injection dates on their own, because it enables them to be independent. This is part of self-care, and they will know what to do if the injection date changes. Now, if you have this, for instance, then you say the injection was given on the 9th of March. Sorry, my cursor is not working at the moment. So if you look there, the injection was on the 19th of March, so you just count 3 months on, which will make it the 19th of June. However, remember, you can give DMPA 2 months before or 4 months after the date. So that is when it is still okay to inject. Right. Now, so we call it the re-injection window. Key points. A client is within the re-injection window if she's up to 2 weeks before or 4 weeks after her scheduled re-injection. Practice this finding her this window with your client. Remind the client that it is okay if she's a few days late for the re-injection. Of course, you will try to ask her that she try to keep to the dates. She should still re-inject if she is within the re-injection window, even if it's not her exact re-injection date, and make sure she knows that she needs to recalculate it there. Now, if she's done, say, for instance, in our example, it was the 19th of March, and then she forget for a week and she do it the 30th of March, then she needs to recalculate a new date. So then it will be 3 months later on the 30th. Okay, what about re-injection visits? Make sure your client correctly calculates her accurate re-injection dates, and then she should calculate the re-injection dates to match the number of devices she will take home. So if you give her two devices home, make sure that she, in front of you, recalculate it for the next 2 months. This is just a question. What suggestions can you think of to help your client remember her re-injection dates? And I think one of the main things that came up is that, first of all, look at the calendar. Some people say it's good to cross out each week, and then make sure that if a re-injection date is, say, for instance, close to a holiday or a market day, child vaccination day, remember that then. You can ask a friend, partner, or family member to remember, or put a reminder on a phone. One of the main things is, do remember with this, some injectables, the menstrual cycle might change a little bit, and the menstrual cycle is not a good strategy to remember. When not to inject. If people are recovering from the flu, they can inject. If she's 1 week early, she can inject. If she's 7 days late, she can inject. The 2 in bold again is when not to inject. If she's more than 4 weeks late for the injection, no, don't inject. Go immediately to your healthcare worker. And if she does not remember the date of the last injection, Before your client leaves, ask her if she has questions, then discuss her options to follow up. Check expiry dates, very important, on the commodities that you give her. Give her the devices and explain that unused DMPA subcutaneous should be returned to you or a health facility, not given or sold to other people. That's the self-injection packages. And then at the follow-up, you have to ask her if there's any question, confirm the re-injection date, confirm storage and disposal, how she has done it, ask her whether she had any problems with re-injection, make sure that she knows the 4 critical injection steps again, confirm that she wishes to continue. If she doesn't want to continue, offer some other options if she wants to. And then again, confirm eligibility. Remember, things can change in 6 months. Support her with the re-injection scheduling and provide supplies for the next injections. Now, 3 last slides. How am I doing on time? I have no idea. 3 last slides, and that is what we have done after the request from countries' ministries of health. So the protocol that we have offers an objective, the master protocol, to align implementation side. It's intended for in-country adaptation, so it's a full protocol and prioritization based on country experiences with DMPA subcutaneous for self-administration, taking into account the stage of introduction or scale up. Not all countries will address all the objectives, and there's a possibility to adapt the protocol for conducting multiple implementation sciences on an individual object or subset. Finalization of country level requires input from stakeholders and implementers at all levels. The role of implementation research and scaling up of the national program. So first of all, if you start on the left side there on the blue one, it's implementation research is designed and conducted so that findings can be documented and reviewed. If you go to the green square, you get actionable knowledge about the feasibility and scalability at all levels of the DMPA subcutaneous. You're looking at the coverage of DMPA subcutaneous self-injection. You look at program design and intervention elements that shape user and community acceptability. And then you look at the replicability of good practices. You learn from yourself and you learn from your different districts. Then if you go to the right side, the dark orange one, the evidence that are available for supporting the policy for uptake and scale up, you use that in the gray one at the top. You deliberate about that, you use it for your strategic planning and expanding. Then if you come back to the orange here, the identification of the knowledge gap that requires additional research, you use that to guide scale up planning and collaboration and research priority setting. Once again, I really want to emphasize that there's no need for any research on efficacy or safety for this. This is just to help countries. If you Burkina Faso experience, I've already mentioned the background in the first. I'm not going to repeat that. The second bullet, this protocol has now been adapted to our ministries of health in Burkina Faso. And as we sit here today, Ghana has also done that, which next will be Madagascar this year. Third bullet, in Burkina Faso, there were a phase 1, and that research in February 2021. This was led by the research organization IRSS and looked at the national policy environment for scaling up of the methods with case studies on self-administration. There were implementation in 6 districts in which the government had scaled up. fourth bullet, the results of that phase 1. There was a very favorable and enabling national environment for scaling up. There were still bottlenecks in public sector training, especially in the training, to use the capacity within the delivery system that prevented essential training and orientation to healthcare workers in the public health service environment. So the physical structure that is the lowest facility level and care in Burkina Faso, where the training didn't take place there. And this was the most important place of this DMPA subcutaneous self-administration. So what happened? The last bullet. There was a supply and demand side barrier specifically for that. IRSS, that is the Research Institute and the Ministry of Health, looked at the research findings that they got there, and they devised a strategy that aimed at a model for effectively rolling out new method in new. So what is happening at the moment? They are doing a review on a second phase where they look at a new training model with mentorship. And then for discussion, my last slide, I am just having 3 bullets there, reminder of the global protocol, and then all the steps that needs to go through to get there. The WHO guidelines, which I hope Dr. Kabir is online now, and then the different countries that we are using that. I do thank you for your attention and the opportunity. Thank you. Back to you. Let me try to stop sharing my screen.